Recording is on.
I'm very happy to be joining you today. So when I was thinking about what I can share with you today, what could be interesting for you maybe, is my experience as both a strictly, let's say, academic scientific anthropologist and someone who also worked in the private public sector for the EU and national institutions using the same, more or less the same methods of research. So I wanted to share with you some insights on how it was done and how it was useful in both of those instances. A few words about me. So my surname is Chowaniec, which can be confusing sometimes, especially for Singaporean airport stuff. Um, I've done my PhD at the University of Warsaw from cultural anthropology. So that's why that's my affiliation. But now I'm currently working as an external expert. So how this presentation will look like. So there are three, let's say, thematic blocks that I would like to share with you. The first one is like a short reminder of what medical anthropology is, rather to remind of some concepts which will be then used in the later stages of this presentation in the next slides. I also wanted to share with you why I think it's particularly useful for this type of research, to researching those particular issues. And then as the last part, I will share with you the examples of some projects that I've either participated in or that I've led that showcase those different applications. And what I want to state at the very beginning is that in all of those projects, I was employed, or I was chosen, or I was in the capacity of, specifically as a medical anthropologist, so cultural anthropologist on the medical side, which is, I think, quite important because it's not only about doing research in a certain way that was particularly medical anthropology. So a few words of introduction and short reminder that the medical anthropology is a distinct, well-established subfield within the cultural anthropology, which is focused, of course, on the illness and health. Both of the concepts are understood as multidimensional constructs. Is everything okay? I heard some strange noise.
Yeah, no, somebody entered,
Yeah?
so it's okay. Yes.
Good. Okay, I don't know this app, so that's why. Thanks. Both are understood as multidimensional constructs, and since its inception, medical anthropology was aligned a bit closer to the more applicable side of anthropological research, which I'll try to showcase today. And as you, of course, know, there are a few key terms here, but I just want to reintroduce them. Within the medical anthropology, there's a distinction between what we understand as a disease and what we understand by illness. So disease is something that is professionally diagnosed and treated, while illness is something personal, something culturally and socially shaped, is the experience of being unwell, which can be understood very differently in different cultures and situations. Also, different illnesses are understood, or let's say, in that sense, diagnosed in different cultures, while disease is more a constant concept, let's say. And as such, health is understood in a very broad sense as a state of overall well-being, which is close to how WHO understands health. Also, those two concepts can be differentiated as different explanatory models. So disease is an explanation used by medical professionals, while illness is explained by ourselves or by our families or friends. There's just different understanding of what this is and what illness is and what it was, what's the cause of it. And I think the best example and the well-known example, I'm pretty sure that you all know it by now, because it's been used again and again. So just to reiterate, maybe use as an illustration, because I'm sure that you're very familiar with that. Tuberculosis as a disease is a bacterial infection, which can be then treated in a, let's say, standardized way with course of antibiotics. But as an illness, tuberculosis was historically, of course, known as consumption, something that is consuming the body. It was burdened with different meanings, especially as shown by Sontag, of course, with high moral significance of the course of the illness. So that was historical perspective. Still today, those meanings and the stigma associated with tuberculosis, which is of course culturally and socially grounded, can delay treatment in some situations. Furthermore, I think good introduction to the things that I'll be talking about today is the Kleinman's tripartite model of categorizing healthcare into three sectors. The popular sector understands treatment as provided by non-specialists, so family, friends, ourselves, in the home setting, in the home context. So as you may hear, I'm a bit sick right now, hence I've put up chicken noodle soup here. Yeah, it's like a part of this popular sector of providing healthcare. Within the folk sector, the healthcare care is provided by non-professional healers, which means that it's, let's say, not structured, not systematic in the same way. Their practice is based on some traditions and local philosophies, while the professional sector understands treatment as something that is structured, something that is systematic, has its own rules and legislations. It's sanctioned, it's official. Those are recognized systems. That can be, of course, biomedicine. Yes, so Western medicine can be used as one, but that could be also Ayurveda, or that could be a traditional Chinese medicine. It doesn't necessarily matter. It's rather a model of how the healthcare is provided. I think what is very important here in this context, and as an anthropologist, I think I've came to that time and time again, that they do quite often, or most often, occur together. They intertwine, they're used simultaneously, they are blended. So as I said, I'm a bit sick right now, so from the, let's say, the popular sector, I have my tea, I have my aspirin, my vitamin C, which was not, prescribed by my doctor. It's something that I'm doing, that is my understanding of the treatment. And then on top of that, I'm also using some drugs that were prescribed by a doctor. Yeah, so from this professional sector. And that could be any number of things that do work at the same time, they do work together. I think currently a bit of an issue in our, let's say, our world now, is that there is so much interconnection between those different sectors that it's not particularly easy to separate them from each other. And more often we see that they do work together in a treatment. Then they can be complementary, there can be some alternatives, but most often than not, they are used together. From the 1980s, let's say, biomedicine, so Western medicine, started to be described and analyzed as this professional system, which I showed you before. So as a sociocultural one with its own practices and beliefs and rules, which are changeable and unstable over time. As such, it is not acultural, so it is not free from socially constructed presumptions. But I want to stress this, and it's very important that I state this as hard as I can, that it doesn't mean that Western medicine or biomedicine is not scientific or it's not wrong. It's not that. It's just to state that it can be analyzed as any other medical system. So as a system which has its own presumptions, it's influenced by time and the context that it's happening in. So when I'll be showing you some examples of the projects, I think that will become very clear that I'm not saying that it's not objective. What I'm saying is that it can be analyzed as a system that is influenced by the context. Why is it useful? So why is medical anthropology useful? In the context of this presentation, and I'd say the overall broad practice within the discipline, medical anthropology and qualitative research in health can be used or are used interchangeably. So the term qualitative research in health and medical anthropology are often used interchangeably. Medical anthropology, of course, more in the academic setting, the qualitative research in health in more private or public type of research. But I'll be using them depending on the context in a way interchangeably, because in the end it's similar enough that it doesn't need to be differentiated in the context of this presentation, of course. So generally, the qualitative research in health, as medical anthropology, as I already stated, has a long history, and its methodology allows to gather insights on what the ill person, specifically ill person in the sense of illness, ill person and others connected with that person think about the whole experience of being ill in the real time, and identify and analyze different interactions generated by this experience across different areas, whether that be home or hospital, including the analysis of the system or systems in which this experience takes place. And this is especially important as the progress of medicine, medical technology, and technology in general generates more complex areas of the medical landscape. And as such, the methodology of medical anthropology in particular is well equipped to research them, those new emerging landscapes, which I will also showcase a bit later on. Here's the good explanation that I often use with my students, and I think it works really well. The good explanation here on the difference between the qualitative and quantitative research in health would be that the quantitative methods are great in providing insight into who and what, while anthropology just provides a better understanding of how and the why. So it goes more into the personal human aspect of this experience, and is able to put that into a broader systemic context. I'm sorry, I have to take a sip of my tea. Which sector that was? The tea for a cold. In the policy making area, also in the evaluation area, they're kind of interconnected. Anthropologists provide some much valued skills and tools, and I'm of course speaking from my personal experience, so that is quite subjective. But in my opinion, what they do bring into this kind of research or studies, policymaking decisions, evaluation, is that they are always people-centered in their research. So they are able, as I said, to connect this micro level of individual experience with macro level perspectives, so systemic perspectives. They do provide a whole toolbox of qualitative methods. They are sensitive to ethical and reflective practices in doing the research with human subjects, and it's a big part of how we do research, of course. We are able to gain access and trust to hard-to-reach populations, which I will show you in one of the projects I'll be presenting. And they are also skilled in providing narratives. So we are good at telling stories, which is very important in report writing, as the findings and evidence is translatable into accessible and actionable findings for different groups of stakeholders, because the issue is that there are plenty of different stakeholders, not only the academic peers. Those are very different people, and we are good at that. We are good at creating those narratives. So when I said that medical anthropology is well equipped in researching more and more complex landscapes because of the new medical technologies and just the development of new technologies, there is a very subjective list of some directions of medical anthropology that I find particularly interesting. So the first one could be, for example, new genetic technologies. So we are able to diagnose new genetic conditions. We are able to test more. There are questions on what is a gene, what is kinship, and connected to that, there are new reproductive technologies and the inequalities within them. Very important sector is the digital health spaces. So how the internet is reshaping medical knowledge and decision making. The whole huge area of medical pluralism and authority, which I already said before. So how those different systems coexist? Are they complementary? Is there an alternative? What are the traditional healing system? How they all work together, if they work together? Yeah. The shifting boundaries between who is an expert and who is like a lay person that doesn't have the access to this knowledge, and especially in the era of the internet, that is particularly important question. Who has access to this knowledge? Who is an expert? Who is the authority within the whole treatment? Also, of course, there's post-pandemic, the research, the aftermath of the pandemic, biopolitics, and we might expect that there will be next one during our lifetime. So the research on the pandemic and how it influenced societies, of course, is very important. So it's like as I said, very subjective list of some directions that I think are particularly important now. Also, to let you know, I'm absolutely okay with sharing this presentation with you. So if you're interested in any of the authors that I'm mentioning here, there's a list at the end if you'd like to have a look at that. So after this introduction, and of course a reminder, because I know that was something that you already know, I just wanted to state it in one place. I would like to share with you some of the projects that will illustrate those different applications. So from strictly academic research to project with applicability potential, that is research that can be used to improve policies, and to examples of using the qualitative research in health for the EU evaluations and studies, which is very much the intention of being an applied science, so applied methods here. And I just would like to restate that in each of those projects, I was in the capacity of someone who is a medical anthropologist. So it is a well-recognized role. Well, how to say it? When we are not speaking strictly about the medical anthropology, we are broadening that into the qualitative research in health. It's very well known and it is very often used. So the first would be the illustration of this, let's say, strictly academic, theoretical, let's say, work, which was the research that I've conducted for my PhD, but it was part of different research projects, different financing structures as well. It focused on the experiences of families managing rare genetic conditions. which are managed we have very restrictive diets. Going back to the point that we are able to access very unreachable populations, that was one of the cases, because for one of those diseases that is listed here, there are only, I think, when I started doing my research, there was for sure less than 100 children with that condition in Poland. I'm pretty sure that less than 100. It drew on many anthropological and social science subdisciplines to analyze what health and illness, as those multidimensional constructs, mean in the context here of Polish system and Polish society, and how these families adapted to the situation. And it employed, let's say, a straightforward anthropological method of field work with families and other stakeholders across different spaces. The key themes that emerge in this research are connected to some of these emerging fields that I mentioned previously. So of course that was the subjective list, because I'm quite familiar with those, but I also think they are quite important. So those key themes included, for example, who is considered an expert and has knowledge on how to best manage these conditions, because it wasn't as straightforward, let's say, as it may look like. How food, illness, disability, rare diseases, and policies on rare diseases were perceived and shaped by the different interactions the families had. The understanding of genetics, heredity, and ethnicity, and the role of grassroots internet-based communities. Some main findings of the research. Management was relational and constantly negotiated. Diagnosis in those cases was not a one-time event, but rather it was a process that was quite long. As I said, parents, it wasn't as straightforward on who the expert and who a layperson is, as parents became lay experts, let's say, with knowledge that often exceeded this of the professionals because of the rareness of the disease and their lived experience with that disease. Diet shaped the entire life of the family and was understood not merely as food, but also as a medical treatment, and it had its consequences, this understanding of the diet. What I also found is that the disability here was not a personal identity acquired by the families or the children or the persons with the diseases, but rather it was systematically imposed, which was quite a big part of the research. And digital platforms, so social media, created new biosocialities for peer support and knowledge exchange. So where this extra knowledge came from, and that whole process was separated from, let's say, the official formal institutions, how it was built and how this knowledge was shared. Is everything okay on your side? Because I cannot see you.
Yes, yes. I think so also there.
Great. Great, fantastic. There are a few articles that came out of this research. I've just listed the English only. There are quite a few more in Polish and in Spanish. And now, because I've been talking for such a long time, there's an illustration interlude. So that's a drawing that one of the children made for me, which is called My Favorite Dish, and it shows carrot nuggets, so not chicken nuggets, carrot nuggets, cucumbers, and what is it? Fries with ketchup, which is very much in line with the diet that she had. So that's her favorite dinner, let's say. Okay, after this interlude, let me just check. for the time. I think you are quite okay.
Yeah,
Good.
yeah, we are in time.
Yeah.
It's okay.
The next project that I wanted to share with you is somewhere in the middle, because it was academic, of course, but it could be used for policy making. So it has this potential. It was not intended as such necessarily, or it wasn't funded as such, but it has this potential of being useful for the policy making, as it included the insights concerning access to healthcare in the EU. I know that some of you were quite interested in this project, so I will try to say about it as much as I can now, and can go back to it. It was a partnership of 4 universities from Germany, from Poland, Croatia, and from Slovenia. As such, the research was limited to those countries. It was financed by the European Commission, and in general, the study examined the role of diversity. We use specifically the word diversity and diversity competency in shaping access to healthcare for selected minority groups, which were race and ethnicity, religion, sexual orientation, gender identity, and migration status. So we limited this research to those 4 countries and to selected minority groups. It had 4 phases spread across 3 years, more than 3 years. The first phase was the analysis of the European Union law, of course, to some limited extent, going back to 2007. And we were looking for regulations that address the equal access to healthcare, on the diversity, and there was like a selection done of those documents that were relevant. And then we followed that with the analysis of the national law, where we comparatively analyzed the national healthcare laws. We used some keywords in our searches in national legal databases, and we supplemented that with some scholarly resources, of course, to not overlook something. The third phase was the analysis of the documents submitted by hospitals. We reached to hospitals in all of those countries, and we asked them to share with us any type of documents that can be useful for us, whether that be codes of conduct or statuses, whatever they thought that it's important for us to analyze. Concerning the issues of diversity and access to healthcare by the minority groups. And that was finalized with the phase 4, which were the interviews with individuals from minority groups and healthcare professionals, which was like structured interviews with representatives of those groups and healthcare professionals. We adapted it to the national context, of course, the interview questionnaires. And then we use thematic analysis to identify key themes and issues and cross-country similarities and differences. Of course, the latter 2 phases were the most in line with the anthropological research, as it included this qualitative component, of course, the phase 4 the most. What were the findings of the phase 1 and 2? So in the phase 1, what we found is that the EU law contains very general statements. It's emphasizing equality as a core value, but it's lacking concrete measures. I think the main reason why is that healthcare in general in the EU and the national law, healthcare is a competency of member states. So is subject to national law and regulations rather than the EU law. So that was the case. There are some soft instruments, such as recommendations or resolutions, that promote equity on this general level, let's say, but those measures, as they are, they lack legally binding force. So it all goes to the national law. And what were the findings there? National laws differed in scope and coverage, of course, as could be expected, with Slovenia and Croatia having the most comprehensive anti-discrimination legislation in healthcare, and Germany had some, and Poland very little. Still, that most of the countries generally avoided embedding the explicit anti-discrimination provisions in healthcare acts, Slovenia being the only country where it was done. Also, we identified some common barriers for specific groups within this legislation. So, for example, for LGBTQ plus patients, and for migrants and asylum seekers. So issues with legal residence, access to public healthcare, which also could be kind of expected. The findings of the next two phases. When we analyze the documents submitted by the hospitals, most hospitals included general statements prohibiting discrimination. So very general statements. And they didn't necessarily address the specific healthcare needs of those various minority groups. Language was the most frequently addressed issue. Even still, the hospitals relied on the ad hoc solutions. So multilingual staff, some interpreters, list of interpreters, the interpreters pool, rather than professional medical interpreters, and that was included in the documentation. Germany stood as one that had some more systemic documentation on the migrant integration. Also, as could be kind of expected, religion was addressed mainly as rights of Catholics to receive pastoral services, and other religious minorities were able to get support or the services only on request. That was also included in the documentation. Gender was addressed as a workplace issue, but not in relation to patients. There were very few practical commitments, such as training programs. We almost didn't receive any information about any type of arrangements to support this diversity competencies in the hospitals. And lastly, in the phase 4, where we introduced interviewed the healthcare professionals and representatives of the minority groups. Here I'll be speaking for this slide, I'll be talking only about the healthcare professional side of view, because that was included in the article that was published, which will also be listed at the end. So those are the findings from comparative analysis between the countries, but only for the healthcare professionals. What they reported was that they didn't necessarily identify systemic exclusion. Rather, they noted some practical barriers. The only area where they noted on some systemic issues was the language, which was found as a systemic shortcoming. They also pointed out into the underfunding, of course, of the systems, which then translated, for example, into the lack of those ad hoc solutions, for example. So even when there wasn't necessarily a regulation on providing translators, they were also unable to provide these ad hoc solutions because of lack of resources. It also translated into a lack of formal training in diversity or cultural competences. While they said that the structural discrimination was considered rare, what they reported on was quite a frequent individual acts of homophobia, racism, stereotyping, pathologization, especially for LGBTQ plus patients, migrants, and Roma patients, which goes back to seeing the medical system where that was happening as also formed by the cultural and societal context. So going back to seeing the medical system as something that is also a system that could be analyzed through this lens. Transgender healthcare was identified as especially problematic due to shortage of specialists and also a lack of administrative procedures. And they also pointed out into the institutional support well developed for Roman Catholics only, with minority religious needs being addressed only on a, let's say, personal, individual basis. So that was the healthcare professionals' view across the countries, but I will say a few more words about what we found from the interviews with the minority groups representatives themselves in Poland, because I didn't have access to findings from the other countries. So you can see what was the sample here, with whom did we talk, and what was quite I'd say important, and which we probably wouldn't find out if we didn't do those interviews, is that the biggest takeaway is that minority groups generally face the same barriers as the majority population, which is very straightforward and understandable, yet it is quite rarely raised in the literature, because when you are trying to find something on the minority groups, exactly, you will find the specific barriers, which is of course much needed and important. But what they shared with us is that they face the same barriers most of the time. So queues, waiting times, unpleasantness, general unpleasantness of using public healthcare, having to use the private healthcare, lack of access to different services, inability to understand and navigate the medical system, the public medical system here in Poland. And the biggest problems, apart from those that they identified, and which is consistent with the other finding, is that the communication barriers were seen as the systematic problem, the lack of access to interpreters. They also found problems at the intersection of law and medicine. So, for example, the issues with the gender transition process, or having access to health insurance and how it was seen. So, also a systematic problem. And another systematic problem was lack of precise procedures for dealing with patients from minority groups. So, as we found from the national regulations and from the documents sent by the hospitals, there's just general lack of procedures. And as such, the discrimination was much more often seen in terms of systemic deficiencies at the level of state and hospital laws and regulations, rather than the interpersonal ones. Which goes back also to this culture and social context where all the things do happen. And as I stated, and what they also share with us is that this lack of regulation, lack of law, meant that healthcare workers had to look for these ad hoc solutions for patients from minority groups, often creating very grassroots initiatives to compensate for those insufficiencies, which is not optimal, of course. These are the articles that were the result of the of this research, and the illustration interlude, which are some pictures from the conferences that we had. We had 3 conferences during the during our project. The picture on the right, that was the conference that we had in Warsaw, and I think that was in late February of 2020. So we didn't shake hands during this conference. As far as I remember, we didn't shake hands. Okay, and now for the for the projects that were strictly were developed to inform stakeholders and policymakers at the EU and national level. So going from this scientific academic research to this applied one. The first one was a study on the implementation of Europe's Meeting Council Plan for the European Parliamentary Research Service, so EPRS. Europe's Meeting Council Plan has started in 2021 as an initiative targeting cancer-related issues through 4 main pillars, that is prevention, early detection, diagnosis and treatment, and quality of life. And it used different instruments from lawmaking to scientific grants and campaigns, public campaigns. And we followed up on whether these were delivered to inform the future similar initiatives. So this is where this policy making aspect comes into place. There are 3 main methodological components here. So structured interviews with different stakeholders, case studies that also include interviews at the national level, and the analysis of available data. And each of those elements included a qualitative research component. So of course, interviews were especially important. As through those in-depth discussions that we had, we were able to learn what stakeholders think beyond official statements, which was very crucial, it is especially crucial for the evaluations. In case studies, we were able to situate the progress of the program within the national medical system context, political context. So again, seeing the medical systems as influenced by the social reality and the setting. And for data analysis, we use both quantitative and qualitative methods for to gain some insights. The qualitative methods were used mostly for text analysis, and in most cases that was just thematic qualitative analysis of the sources. What were the main findings here? First of all, we would not have been able to reach our findings without these qualitative components, for sure. In general, the program launched most of its actions. The most progress was delivered in the digital and clinical developments and in creating research networks. And the least was achieved in this prevention pillar, which was seen as a shortcoming linked to industry lobbying and challenges in creating new legislation. From the perspective of using qualitative research methods in policy making, the stakeholder insights, as I said, were particularly important. They reported that they saw this as a powerful initiative and that still lacks in implementation, unfortunately. And as such, this example and their insights on the implementation serves as a good blueprint for similar programs, though it requires adjustments. And that's exactly how it will go. So in this report, we also included some recommendations on what can be done better, based mostly on those stakeholder insights. And as the European Union will be developing similar programs of the same nature, those will be used to improve on how those programs are developed and how they are implemented. And here's the report that summarized the findings. And the last one is the project that I delivered for the Council of Europe office in Georgia, which was an assessment of the needs and current situation of persons with disabilities, which was guided by the framework of the Article 15 of the revised European Social Charter. And the thematic scope of the study was guided by the said article. So it focused on education, employment, and social inclusion of persons with disabilities. The methodology included desk research and fact-finding mission, and this fact-finding mission was this most important and qualitative component of this whole research. And we also validated the findings with the stakeholders. As a result of this research, some themes emerged, including several also systemic shortcomings that were a result of the political atmosphere and the legacy of Soviet era. And as such, they were all deeply embedded in the historical and social context of Georgia. And also some cross-cutting issues did emerge. The main findings, I'd say that the main finding was, as simple as it sounds, that the current situation of persons with disabilities in Georgia is very much a result of different factors, mostly historical, social, political. And this resulted in lack of resources across different areas and sectors, some legislative inconsistencies, and that is very important because it's very much embedded in the culture and the understanding of the disability. So still present stigma of disability hindered social and workforce participation of those persons, and that was very, very obvious how it plays out in the whole situation. That report that was created after this study was completed, and for the interlude, these are some pictures of the stakeholder consultations that we've had. As you can see, I'm at the very bottom one, and I felt a little bit like a true 19th century anthropologist because I had interpreters with me because unfortunately I do not understand Georgian. I think this meeting was in the state employment agency of Georgia. Also, you may see that there are European Union flags at the desks. So just to keep in mind that I was there during the protests. So just to let you know, most Georgians are very much in favor of European Union and being part of Europe. Some conclusions on the role of qualitative research in health. As I said, the qualitative research in health, here represented mostly by the medical anthropology, has a long-standing history and has been applied in theoretical as well as applied research from the very beginning. Its advantage lies in the timely observations that it can deliver that are in-depth and are context sensitive, not necessarily accessible through other methods. The ethnographic approaches and methods are especially useful when engaging with vulnerable populations, vulnerable groups, such as patients, such as minority groups. Due to professional sensitivity to research participants and close connections, anthropologists are able to develop with the groups. Such research is useful when studying complex and emerging issues, as I try to showcase, as it allows for connecting these micro and micro levels. It also allows to examine medical systems as socially and culturally embedded, which doesn't mean they are not scientific, they're just culturally embedded, which provides deep insights into the practice, but also prejudices, as we saw in the projects on the access to healthcare. And at the policy-making level, it is able to inform decisions by offering evidence-based yet in-depth insights to inform decisions. Here's the literature that I've used apart from the articles and reports that were mentioned as part of the project. So happy to share that with you after the meeting. Okay,
Sure. Thank you
Thank you
very
very
much.
much.
Thank you. We thank you very much. Wow, that was a lot of interesting stuff. And I open the Q&A session, and if there are online or if there are from, please raise your hand if there are from online questions. So in the room, might someone there might see who wants to talk, and he can come or not. Please, there is no still in online. So if you want to go in the room, so I have also a lot of questions. We don't hear you, Marin. That's something you have to unmute yours. Yeah.
Okay. I just want to express my gratitude and even admiration for this extended paper, which is very rich in arguments and databases and so on. We are, at least myself, I am very interested in the possibility of providing more arguments, if possible, as to a basic question from my point of view. Say, you speak of medical anthropology and the possibility of applying this branch of anthropology. My first question is, to what an extent is this really anthropology? And probably uh, we can ask and reflect upon the possibility of interdisciplinary research, within which anthropology is just one research division, so to say. To me, is not sufficiently clear. I want to say, to what an extent this kind of research is anthropological. You evoke, for instance, doing ethnographic research, and also recognize the importance of conducting fieldwork studies in different areas. And yet, to me, your perspective seems to be a little bit top-down one, not from bottom up. I mean, this is not sufficiently clear to what an extent your research is conducted from the grassroots, so to speak, and what kind of informants do you use to interrogate during your inquiries? And last but not least, what about the ethical aspects of such an inquiry? Is the anthropologist required to comply with different ethical codes in conducting his research, or is it just applying his own knowledge, and that's enough for the moment. Okay, I don't want to insist. Thank you very much once again for your paper.
Thank you very much. I understand your concern, and this kind of a journey that I had to undertake myself, in a sense, going from this, let's say, classic anthropological research that
Okay.
I've always done in different projects. So I'd say the closest to that would be this project that I've done as part of my PhD thesis. It was like a long, full-on field work, anthropological work with the family. So I think that's quite clear, and how that was in anthropology. The thing is that I think as anthropologists, we quite often do not see our value to the degree that we should. because as anthropologists, we do develop different methods of doing research, which are not necessarily available for other disciplines. Of course, there is qualitative research in sociology as well. I think there's this connection, so I'm not dismissing that. It's rather that we are quite able to develop different methods and different tools of engaging the participants and gathering these insights, which go beyond this strictly understood field work as we understand in a classical way. So multi-year research, being with this group, talking with them all the time, participating and such. So what I'm trying to say is that it is not this classical anthropology in that sense. Rather, we are, as anthropologists, we do have a great toolbox that we can use, that can be used in other types of research. So not necessarily this longitudinal field work where we spend our time with the participants to gather those deep insights. Rather, there are different methods that we do have in our toolboxes as anthropologists, which we do develop in our work, that we can apply in other contexts, to be a little bit more timely, because there is, especially for the policy making or evaluations, there is a time pressure. It has to be timely. So there isn't, you don't have 3 years to go in depth into the whole thing, as you would probably do in classic anthropology. But we can use some of those tools there. And the projects that I showed you, especially the two in the middle, so one about the access to healthcare, and the second, which was the evaluation of Europe's Beating Cancer Plan, those were interdisciplinary. I'm not saying they're anthropological, parts of them were, and it works pretty well, because if you are using different methods, you can cover more issues, you can cover more areas. So interdisciplinary is the key. Interdisciplinary is the word where these methods can be used, but of course, to a limited degree. It's not like a full field work. We are not able to do that in such a short time, but we can apply it. We can apply some of those methods to that research, and there is a great value in that. It's just maybe a different understanding of that.
Just let me give you an example of what I mean by doing applied anthropology in another context, in that of North America in the 80s, when a researcher called Hazel Whiteman has conducted such a research across three different ethnic groups. In a given ethnographic context in Miami, and she tried to compare the perspectives from Cuban groups, from Mexican one, and also from Puerto Ricans, just trying to document their specific folk culture of health take caring. So her approach was interesting from a methodological point of view, in that she engaged on the one hand in a comparative approach, and then by getting involved in conducting case studies at the ethnographic level with different teams of researchers, each of one specialized in the minority groups from there. The result was what she called to be rather a pluriverse of health systems, rather than the official or medical modern system. And each of these ethnic group was equally relevant for providing a series of evidences regarding how they, say ad hoc or at home, used to find out different solutions to their health issues in the context. To me, it was an example of really applying anthropological knowledge and the methodology as well to a given context. Well, this is what I wanted to say. Okay.
Yeah, absolutely. I do agree. I think there's no disagreement here. I think it's rather about, the I'd say part of this conversation, part of this discussion is of course the finances.
Okay.
So I'd say that of course I am for this kind of research because I am familiar with that, and that's how I'd like to do anthropology. And if I be able to get the financing, then my next project will be very much aligned with this classical anthropological type of research, so long fieldwork and such. The issue is that when I'm saying applied, I mean that it's something that is requested, something that is needed by the higher levels, applied in a sense of having a potential effect on the policies, on the regulations, on the situation. And as such, it very rarely happens, as far as I know, it very rarely happens that we are able to conduct such a research that you've mentioned as part of, let's say, official national agenda of healthcare, yeah, or something like that. It very rarely happens. So I'd say what you are saying has this as the research that we've done about the access to healthcare is something that is applied in a sense that it has this potential to be applied. It provides insight that then could be translated into some solutions, some practical solutions. And in that sense, it is applied. What I'm more aligned with is that here in this presentation, and I'm not saying that it's correct. It's rather in the sense of this presentation that I've shared. Applied means on request. Applied means something with practical translation, translation to practical solutions, which was requested, and as such we are able to apply some of these methods to gather those insights, to analyze them, and to provide some solutions.
Okay.
In that sense, it is applied. You also had a question on the ethical side of things. Yeah, of course, we are required to follow the ethical procedures in all of them. Yeah, I mean, it's no different for the. Of course, there are different procedures for the academic research when it goes through the committees at your university or whatever the situation is. For the EU funded studies and programs, I think it's a bit higher up. I was not a part of this. I'd say the main thing is that it's always, we also always do request the informed consent. So we are informing all the participants about the purpose of our meetings, the purpose of the research, and they have to sign the informed consent forms for all of this research. So we are obliging with the ethical protocols, whether that be of the institution, whether that be of the institute or university or whatever it may be. I know from it very much depends, as I said, on the institution, because, for example, I was doing some work for UNICEF, and UNICEF has its own ethical protocols to be followed, for example, in the research, which is quite understandable. Yeah, so research with children, vulnerable groups. So they do have their own. They do require certification of the ethical course, which I've done as well. But also the whole protocol of the study, and that has to go through their ethical committee. So that very much, I mean, in the end, we do apply the ethical protocols. It just depends on the formal side. It depends for whom the research is done or where the research is done. Yes.
Okay, thank you very much. Sunt alte întrebări? Puncte de vedere?
Online,
Just a moment.
yeah, of course.